today I am going to interact with Dr. Sagni Mukherjee, and I am Dr. Saurabh De. I am practicing physician in Hooghly, and today we will be discussing an early initiation of empagliflozin and Linagliptin combination for optimal glycemic control in type 2DM management. Dr. Sagni Mukherjee will give his brief introduction, but before that, I just want to tell a single line for him that he is my mentor. Whenever I have a chance to talk with him, I learn a lot, not only of medicine, but about life also. With this brief introduction, I will channelize the words for Dr. Sagni Mukherjee for her introduction. Then we'll be starting the session and discuss few salient points of today's discussion, how Empalina is relevant in today's practice. To Sagnigda.
My name is Dr. Sagnik Mukherjee. I'm one of the doctors who treat diabetes and endocrine problems in Kolkata. I'll be talking with Dr. Saurabh De, who is basically very active consultant physician and as well as like my brother and very active person, and he treats plenty of diabetes patients in the suburbs and guides them like a leader. And I have seen his initiative several times in several platforms. He's very active in social media also. So I would ask him to conduct the whole meeting and to lead us to the inferences that we get from the treatment of the diabetes that is required in the nowadays, what is the trend, and how we can properly control the blood sugar in several of our uncontrolled diabetes patients over a period of time. Thank you. And over to Dr. Saurabh, please.
First of all, Dr. Mukherjee, we will be starting with the first important part of the important question that how early would you add a FDC after a metformin in your clinical practice? Considering many type 2DM patients having a high baseline HbA1c at the time of presentation. So essence of the question is that now we are in a world where large number of FDCs are available. Still, somehow we have to judge patient-wise, and there are several. This meeting will be heard by several primary care physicians also. And in the last 10 to 15 years, long back after the UKPDS, our trend of practice have been gradually being changed. There were different discussion of Dr. DiFranzo, different meetings we have seen. So I just want to hit the most important part that when after metformin you think of combining another FDC combination apart from metformin in the clinical practice, what is the rational HbA1c when we think, or rather we should not think of HbA1c as per the recent trend? What is your take on this question?
Okay, thank you for asking that. We have to understand the pathophysiology of the diabetes. There are two sets of patients who actually come to us during our clinical practice. If they are drug naive, they have not taken any drug in the past. This type of patients are two types. Number one type is those patients who are having very high amounts of blood sugar, like say their blood sugar in the range of 300, 400, something like that. They are unaware of that. Then, if they are aware of them, they actually posed no significant effort on controlling their blood sugar, or they are not willing to do that. Another subset of patients are those who come with a early diabetes or pre-diabetes. Their blood sugar has just started increasing and they're very much concerned about it, and they ask for treatment in the very early stage. Usually in the first subset of the patients, we see that they have simultaneously comorbidities or complications that already has set in. And in the second subset of the patients, they are the early detected patients in whom we have some time. For those patients in the first subset, the main aim nowadays is to reduce the amount of glucotoxicity they are having. Now, the amount of glucose that is present in their body actually killing their tissues. How? Because if they are insulin deficient or if they are insulin resistant, either they are insulinopenic or they are insulin resistant. So if they are insulinopenic, for those patients who are losing weight, thirsty, polyphagic, protein deficient, with complications, GFR low, we have to start with straight away. We have to start with insulin. There is no way basically scope of giving or trying drugs on those patients. The same is applied for the LADAs also. But those patients who are insulin resistant, obese, not losing so much of weight, is not having so much of complications, the chances of reducing their glucotoxicity is by prescribing an adequate amount of medications. Now, this adequate amount of medications has been categorized into three types. For those patients who are having atherosclerotic cardiovascular disease and obesity and insulin resistance, high blood sugar, we have to, if their HbA1c level is more than 7.5 to 8, basically platforms including ADA, ESC, everyone is telling we have to start with those drugs which is having maximal amount of cardioprotection. They are either SGLT2 inhibitor or GLP-1 analog. For reduction of the weight, either GLP-1 analog is the first choice and SGLT2 inhibitor becomes second choice over and above metformin. Why they should be started with the combination of medicine? Because it has been seen that single use of lifestyle modification and single use of metformin will definitely not control their blood sugar level adequately, such a way so that their glucotoxicity can be prevented, or I, even if it is not prevented, can be minimized. So combination of drugs is required because their HbA1c reduction is more than 1.5% is required for those patients. For those patients who are coming in the early stage of diabetes, I think, and almost all the schools of diabetes treatment think that for those patients, lifestyle modification, initiation of the metformin, and several other second line drugs sequentially, not simultaneously, is still the best way to approach, because for these patients, we have enough time. Lifestyle modification sometimes makes their diabetes well controlled, and adding a metformin is sufficient for next 1 or 2 years for their glycemic variability to become minimum and overall glucose level to be in the satisfactory range, and HbA1c will be in the range of say 6.2, 6.3, 6.4 maximum, nothing more than that. I have seen in my clinical practice many of the patients may go up to the level of 5.6, 5.7. So overall their dysglycemia, dyslipidemia level also remains absolutely fine. Now you have to consider Indian subcontinent where the cost of medicine is high and the treatment is not state supported like that in the UK. We have to think about the drug burden and that we inflict on the patient. So for those things, those early parts who actually come to our clinical practice detecting the diabetes, we still recommend to use single dose metformin or by times daily metformin up to its dose of 2 gram and to wait and watch how they are doing. But for those patients who has come with a relatively high sugar level and high HbA1c level and whom the glucotoxicity must be prevented or minimized, the combination therapies are absolutely required. What to Saurav, please?
Thank you, Dr. Mukherjee. Do you think that Empalina combination do actually have a good role against cardiovascular risk reduction along with glycemic control?
So there are two subset of patients over there. Those patients who are having high blood sugar and most probably on insulin or metformin simultaneously with Empalina. They are one subset of patients. Another patients, subset of patients, those who have high blood sugar but they are insulin metformin intolerant. For those patients who are metformin intolerant, we can straight away start with Empalina if they are having excessive amount of blood sugar and who needs a proper reduction of the blood sugar as early as possible. Now, the combination Empalina, as per C, actually controls the pathophysiology of the diabetes very well, as we have seen by the demonstration of Dr. D. Fronzo. The pathophysiology of the diabetes depends on and is guided by ominous octet, and we have clear picture of ominous octet in our mind. We know how actually this ominous octet controls the pathophysiology of the diabetes, and if we consider the mechanism of action of empagliflozin and linagliptin, we'll be able to see that this empalina combination points and focuses on every aspect of this ominous update and try to reduce the disease burden by inverting the overall pathophysiology of the diabetes by reducing the insulin resistance, increases inhibiting effect on the pancreas and the postprandial blood sugar, increases the glucose uptake by the liver and also in the muscles, increases the chances of reduces renal threshold and in turn it excretes excess amount of glucose from the body and in turn reduces the amount of calorie that is present inside the body and helps in maintaining the blood sugar level both the preprandial as well as the postprandial. Now, empagliflozin in the EMPA-REG outcome trial, we have seen an EMPA-REG extrapolation in the heart failure trial and also in several other heart failure trials and also in the atherosclerotic cardiovascular disease trials like say ADVANCE, DAPA-HF, and several other trials that has been discussed in the Endocrine Society and the Diabetes Society, the European and also in the American and other associations, we have seen that the empagliflozin actually reduces the cardiovascular burden by several mechanisms like reducing the endothelial dysfunction, reducing the nitric oxide level, reducing the oxidative stress. It also prevents the progression of the renal adverse effect that actually happens like glomerulopathy or tubulopathy over a period of time with diabetes and also reduces the weight that is very important for those patients who are overweight by reducing the amount of sugar inside the body, excreting more sugar through the glomerular filtration and also causes overall reduction in the brown fat that has been demonstrated by several DEXA scanning and also causes reduction of the amount of protein and that is excreted through the kidney and reducing the overall albuminuria over a period of time and progression to frank diabetic nephropathy and renal failure is also prevented. So several ways empagliflozin actually prevents the glucotoxicity and prevents in the patients to develop several complications, including stroke, heart attack, and renal dysfunction. Only threat that was posed several years earlier was the amount of limb amputation with the empagliflozin and dapagliflozin, but it has been clearly demonstrated in the EMPA-REG outcome trial that the empagliflozin does not increase the amount of limb amputation that is necessary, and also the genital infection, recurrent urinary infections, and fournier gangrene, chances of fournier gangrene was not higher with empagliflozin, but it is slightly higher with dapagliflozin. About the linagliptin, it is a very good novel drug that has been introduced into the clinical practice as a TPP4 inhibitor, and this is the drug which has almost all its excretion through the liver, and the dose reduction is not required for those patients who are having renal failure. Now, for empagliflozin, the lowest amount of GFR that is permissible is 35, but we don't recommend for those patients with less than 45 GFR to give SGLT2 inhibitor because they are not effective for them. For linagliptin, less than 30 GFR, even in the less than 30 GFR, if we give linagliptin, we do reduce its dose. So for renal failure patient, these two drugs are ideal. For as a DPP4 inhibitor, linagliptin is a potent drug that reduces both preprandial and postprandial hyperglycemia by increasing the amount of incretin present in the body. And whenever the patient takes food, the amount of incretin inside our body increases. That actually helps in insulin secretion, and the DPP4 enzymes that actually destroys this incretin inside our body, they are inhibited by linagliptin, so that incretin that is present in our body persists longer, producing a long-term effect in reducing the blood sugar, both in the postprandial period and as well as in the preprandial period. This is a drug with a little amount of body weight changes, Both these drugs have a capability of reducing the blood triglyceride and also mild amount of LDL cholesterol. And the osteoporotic effect of empagliflozin is also very less. Linagliptin don't have any effect on the bones, but it increases the protein concentration in our body, so it has a muscle preserving action as well. So overall, empagliflozin and linagliptin is a potent and effective combination that addresses every aspect of the defrontosominous octet and every pathophysiology of the diabetes can be addressed with this combination. And usually with this combination, the amount of the HbA1c reduction is around zero point 0.8 to 1.2. So there is significant amount of HbA1c reduction, but in our clinical practice, I have seen with these drugs, HbA1c reduced is up to 1.8. In some obese patient with diet control, HbA1c reduction can be done up to 1.8 to 2. So usually patient remains all right and optimal glycemic control is achieved. And the CV risk reduction has been demonstrated in several trials that we have already discussed, that Empagliflozin outcome trial and DAPA-HF trial and several other atherosclerotic cardiovascular disease trials that has been demonstrated that SGLT2 giving SGLT2 actually reduces the severe adverse cardiovascular event, including heart failure, and the major all-cause mortality is also reduced in some patients. Only thing that we have to consider with this medicine is that in cases of sick days, and for those patients who actually have genital infections, these two things may progress with empagliflozin, and patient may suffer from fever, infection, poor appetite, nausea, vomiting, or diarrhea kind of thing. For those patients, these drugs may actually work erratically, and in those cases, we have to be careful about glycemic ketoacidosis that sometimes present for SGLT inhibitor for those patients who are acutely sick. Otherwise, the side effect profile is very beautiful for these drugs, and we have safely used these drugs in our clinical practice several times. Over to Dr. Saurabh, please.
Thanks, Dr. Mukherjee. I believe Dr. Mukherjee have covered most of the part of the MPL and a combination and their point of use and how you will select our patient to choose this kind of a good combination. And at the same time, you have aptly told most of the things regarding the empagliflozin as a molecule and the linagliptin as a molecule. And what actually I feel regarding this molecule like linagliptin is a right and forget DPP4 inhibitors as a molecule which can be used in an entire spectrum of CKD or rather DKD. At the same time, empagliflozin, I actually, in diabetes, what I personally fears of most of my patients, they suffer from two important aspects. Number one, the problem renal DKD or rather CKD. And at the same time, this CKD and DKD patients, they have a high incidence of sudden cardiac arrest or rather sudden cardiac death. Truly, there are different SGLT2 inhibitors who are claiming their importance regarding the heart failure. But still today, if you go for the class variations, this empagliflozin still have the figure of have a considerable decrease in sudden cardiac death. And only this molecule have a definite robust data against the cardiac death part. So taking into this consideration, I would always be like to choose this kind of a molecule in most of these patients who actually, as Dr. Mukherjee told, actually need this molecule. And as these molecules are backed by a robust evidence that will, and truly in our clinical practice also, we able to see the importance of this kind of a molecule if it started at the right time. And those patients we have started, they're still jolly well not only in control at the same time gradually. What Dr. Mukherjee was talking about different benefits regarding the protein loss of protein during the urine has been stopped. We have seen that drastic decrease in urine ACR. We have able to see the increase in HbA1, increase in hemoglobin levels. We are able to see the several other the exertion of breathlessness and several other complaints because it actually in long term mechanistically helps the body. And if you go in the biochemical part of it, it's gradually shift our entire system in the ketone body utilization, which is in the long run helpful for cardiac mechanics. With this, I will be going for the last part of the question of this entire program is that what actually what are considers, and though Dr. Mukherjee have already been dealt this part a little while, but I just want to touch on one or two important things that who and what actually you think that the rational individual have getting this particular combination drug together after the metformin, number one. Number two is that What are the considerations we should think as you are told about GTI and UTI? Apart from that, if anything more to know from you regarding this combination. And another third important part is that if somehow we not able to add this molecule in the first part of the domain of the treatment, can it be chosen as the third or fourth drug, fourth line of management in diabetes? If so, and what are the things we should be keeping in our mind when using it late in the period of diabetes? To you, Dr. Mukherjee.
So in our clinical practice in India, we actually encounter financial problems. Many of the patients who need these drugs sometimes don't get it because of the financial burden. And many of our patients are from the poor or socioeconomic strata. So as we have seen, sometimes we feel that this drug has to be started early, but we have to choose relatively cheaper alternatives to reduce the glycemic burden in them because many of the times they can't afford it. When we are doing it, I think if the patient is non-obese, then definitely sulfonylurea and pioglitazone are the good choices because pioglitazone is definitely acts on deeper gamma and definitely acts on the lipid much more than several other drugs and cardioprotective reduces LDL cholesterol as well as triglyceride level, but not as robust as other drugs like saroglitazar, which acts on the PPAR alpha as well. The potency of pioglitazone acting on PPAR alpha, peroxisome and proliferator activated receptor alpha, slightly less than that of saroglitazar, but even then saroglitazar is very costly. Another group of drug which helps to reduce blood sugar in many patients, mainly postprandial blood sugar, is niglitinide and its other analogs like empagliflozin. Even though it has been recommended, it has been said that they produces lactic acidosis, but their lactic acidosis is just like the lactic acidosis of the metformin. We have all read that, but never seen that. So if the patient is not very sick and is well established that these values will not change, and I don't think that the lactic acidosis is coming way. But even then, repaglinide is slightly less costly or slightly more costly than sulfonylureas. Among sulfonylureas, glycoside and glycoside are good choices. Glimepiride even is not a bad choice, but all these drugs increases weight. The weight gain is less with glycoside and slightly more with glycoside and glimepiride. But if the patient is non-obese, these are a really good choice for controlling as on a low cost therapy. But if the patient is obese and weight reduction is absolutely necessary, then you have to concentrate on those drugs which are either weight neutral or produces weight loss. Here comes the choice of SGLT2 inhibitor or GLP-1 analog. Now we all know that as a GLP-1 analog, semaglutide has come in the market, which is an oral GLP analog and claims to reduce weight, but the price is very high. So empagliflozin is a relatively better molecule. That is now there is also another consideration that has to be kept in mind that we have DAPA, which is relatively less costly. Then why should we prescribe empagliflozin? Because definitely DAPA also produces its class effects like that of empagliflozin, but renal outcomes with empagliflozin are better than that of with DAPA. DAPA reduces atherosclerotic cardiovascular disease. DAPA reduces heart failure that has been documented in several trials. But the kidney protection which has been seen with IMPAREG outcome trial and the heart trial and Emperor trial, Emperor Preserve trial, all these trials have definitely shown that the renal outcome with empagliflozin is far better than that of the DAPA. Side effect profile of empagliflozin is better than the DAPA. The chances of osteoporosis with empagliflozin is minimal, which is more with DAPA. And with renal failure patients, the suitability of empagliflozin and data on empagliflozin is much more robust than that of the DAPA. This makes the empagliflozin a better choice for those patients who are having a renal problem and reduction of the albuminuria that has been demonstrated with empagliflozin has definite advantage over DAPA because it has not been demonstrated with DAPA, though it has been said that it is a class effect, but it was demonstrated with empagliflozin, not with dapagliflozin. For all this reason, those patients who are having increased albumin creatinine ratio, the treatment with empagliflozin is more recommended than that with dapagliflozin. And but even though then it should be kept in mind that it has been paid as a class effect. So the indication of empagliflozin is clear cut. Among linagliptin, so we have to choose another agent actually which reduces postprandial blood sugar and will be weight neutral for those patients who are having increased amount of weight, less amount of muscle mass, mainly in the limbs. Now, limb muscle mass is a separate indicator of the diabetes complications. It has been seen by the DEXA studies that when there is limb muscle mass is relatively less, the chances of having diabetes complications, including retinopathy, is higher, and chances of not having proper glycemic control is also higher. So, linagliptin actually produces a relative reduction in the postprandial sugar. Empagliflozin and linagliptin simultaneously decreases glycemic variability in such a way that the overall time in range increases to the range of 70 to 80%, which is absolutely required for the patients and which you have metformin. With it, you get a robust effect on the patients and ultimately the patient benefits most. Now, initiating this combination, keeping in mind its side effect profile, which is very less, actually makes you understand that therapy with these three drugs, metformin, empagliflozin, and linagliptin, actually potentiates the lipid lowering and also the sugar lowering effect at its zenith. So the patient benefits more and over a period of long-term efficacy in terms of its cardiac safety benefit, hepatic safety benefit, renal safety benefit, eye, and also the limb preserving effects are there. So these drugs are going to act on several aspects of the comorbidity that usually patients has in the long term. So initiating in the drug and maintaining this thing for the long-term period will definitely save the patient from long-term complication, which in turn reduces the chances of acute coronary event and or acute stroke or heart failure, and secondarily reduces the cost of burden on the patient, and ultimately the total cost of the therapy remains less than treatment with relatively low cost drugs over a period of 5 years or 6 years that has been demonstrated. So the initial investment done by the patient actually doesn't go in vain, and the patient benefit by reducing the amount of burden in the long term, and also the quality of life improves. So ultimately, it is a good choice to start with all these drugs because the extra amount of money actually is not wasted. Over to Saurabh.
Thank you, Dr. Mukherjee. And now before the conclusion, I just want to end with few of important words that definitely the last words that still we in India, in a country, developing nations, we value everything with the money because it's very, very skeptic for our patients when we are trying to use these costly drugs. But if you consider that the price of all drugs to be same and then judge the potency of the fixed dose combination, tomorrow if you in the morning if you're able to know that the price of this molecule that is lina and empa have slashed, and what actually we do at that point of time, actually we should always go with a drug. We have a robust evidence after the advent of the empagliflozin in the treatment of diabetes. The entire paradigm of the diabetes management have been changed. Initially, I always remember the words of one of my teachers. I was delivering a talk on empagliflozin around 5 years, 6 years back when it was newly introduced in the market. The person was basically a very good pathologist. He told me a thing that, Saurav, you're talking of a molecule which is not a OHA. It's not a diabetic molecule at all. It's basically, it will emerge as a molecule of preventing diabetic complication. Now I am able to understand what's the wisdom that person had. That in the beginning, when we were all thinking about this cardiovascular death and diabetes, at that point of time, we were able to understand the benefits, the pleiotropic benefits of this molecule, in the which we are able to witness in the recent days. Truly, now as Dr. Mukherjee was talking that, telling that empagliflozin is the molecule which have robust data not only in the cardiovascular part at the same time the renal prospect also, which is backed by and combination with linagliptin, which is known for its renal health. And we need not to have a dose reduction in complicated disease. Most of the time, as we practice as a consultant physician or diabetes, we get different patients with multifaceted problem. We get patients we have having a polypharmacy. We are very skeptic of using drugs in these individuals. And FDC combination of this and the linagliptin and empagliflozin is so good in targeting this group of the population, because this kind of a molecule is just right and forget only. You should thinking because it can be used as low as 25 or 30 EGFR. We talk about EMPA. So with this, I thank everybody for your patient hearing, and I thank purposefully my mentor, Dr. Sagni Mukherjee, for giving his precious time in this talk and enlighten all of us with this explicit involvement and explicit discussion of not only this impalina, at the same time, how to we approach diabetes per se, diabetes individuals as per se. Thanks for my end.
Thank you, sir.